The following is our technique guide for in-office needle arthroscopy for superior labral tear debridement. Advantages of this technique include the ability to obtain real-time assessment of lesions and pathology while discussing treatment plans with the patient, an avoidance of the operating room and anesthesia complications, and a faster recovery. Disadvantages of this technique include a potentially long learning curve with a wide-awake patient and 0-degree scope. The patient is seated comfortably on an examination table with the back of the bed set approximately to 70 to 80 degrees, and the ipsilateral shoulder is positioned so that the posterior, lateral, and anterior aspects of the shoulder is unobstructed. Using sterile technique, the patient's extremity is prepped and draped, and the arm is supported on a padded Mayo stand in slight forward flexion and abduction to allow for optimal entry into the glenohumeral joint. Relevant surface markings include the acromion, clavicle, coracoid, with the posterior, lateral, and anterior portals marked as above. Prior to the procedure, the portal sites are injected with a 1-to-1 mixture of lidocaine with epinephrine and marcaine. A standard posterior arthroscopy portal is made. Using an 11 blade, a 2 mm stab incision is made to accommodate the 1.9 mm 0-degree viewing needle scope. A diagnostic arthroscopy is conducted viewing the labrum, glenoid, humeral head, the long head of the biceps tendon at its insertion, the rotator interval with the MGHL and subscapularis, the articular surface of the humeral head and the rotator cuff at its insertion. The anterior portal is then made under direct visualization using a spinal needle to ensure passage superior to the supraspinatus tendon and perpendicular to the long head of the biceps tendon. The spinal needle is exchanged for a probe and the biceps tendon is probed for signs of inflammation. The labrum can also be probed at this point to check for stability. A 2 mm shaver can be used to debride the superior labrum until it is back to a stable margin. Portals can be sealed primarily using adhesive wound closure or with simple nylon sutures if the surgeon feels they are necessary. Pearls of this procedure include adequate patient selection and a thorough comprehensive discussion with the patient regarding expectations for the procedure. It is crucial that there is adequate time between local anesthetic and the procedure. Additionally, we recommend adding epinephrine to the saline to improve visualization. Pitfalls include poor patient selection and poor portal placement given the 0-degree needle scope.